Well, hello, friends. It is 7 o'clock, and we're going to get started. And I am happy to have our attendees with us. Attendees, I'm just going to make a couple announcements. I'll make them several times, but I just want you to know that we're going to have two presentations, and then you'll be able to answer any or ask questions, and then we'll have answers after we get started. So we still have people joining, and they will probably keep joining in between, but we want to respect everyone's time and get started. So Dr. Lawler, if you want to turn on your camera, then I'll introduce everybody, and then we'll go ahead and get started. Welcome. Thank you very much for joining us on this Sunday evening. I said as I was leaving, my 6-year-old grandson says, "Graham, where are you going?" I go to work. "I'm going to work." And he said, "It is late to be going to work." So he didn't think that was a very good idea. But this is very important information, and I'm very, very pleased that our guests were able to join us this evening. So tonight you will see two presentations by two very, very important people in our field, our medical field. When we're educators, we talk a lot about how important it is for folks to understand what it's like in the classroom. And I can't imagine what it's like in the medical field right now. So we want to give our thanks to not only our attendees, which a lot of them probably are educators, but there are other people who are joining us this evening as well. I am Jenny Benson. I am the president of the Nebraska State Education Association. And tonight I'm joined by Dr. Matt Blomstedt, who is our Commissioner of Education for Nebraska. Hi, Matt. How are you doing?
I'm doing well, and of course, my Sunday so far has been home improvement projects. So this is a good break for me, actually.
Well, you know what? We take every minute we can get to do the things we need to get done. So
That's right.
I totally understand that. We are also being sponsored by our friends at the Administrators Association, and we will be joined by Dr. Mike Delaney as well. And if Martha, will you keep an eye on the attendees? And when Dr. Delaney joins us, I'll let him in as a panelist. But tonight, we have these two experts who are joining us. And we are very pleased to have with us tonight Dr. James Lawler, Executive Director of the International Programs and Innovation at the Global Center for Health Security. And we have Dr. Gwenn Skar, Associate Professor in the Division of Pediatric Infectious Diseases and a practicing physician with Children's Hospital and Medical Center's Specialty Pediatric Center. That's a mouthful. And we got both of you. So tonight we're going to start off with Dr. Skar doing a presentation. The rest of us will turn off our camera and our microphone, and we will disappear while she does her presentation. And when she is finished, then we will have Dr. Lawler do his presentation, and then we will open it up for questions. So thank you, friends, for joining us, and we will talk to you shortly. Thank you.
Thank you all for asking Dr. Lawler and myself to talk with you tonight. So as they said, I am a pediatric infectious disease physician that practices at Children's Hospital as well as UNMC. So I'll be giving a brief pediatric COVID-19 overview, and then Dr. Lawler will be following, talking more about COVID mitigation strategies in schools, as well as sort of what's next on the horizon in COVID. Before we start, I do want to make you aware that I receive research funding from the National Institute of Health as well as UNMC, but those research projects are completely separate from COVID. And then today we will be talking about emergency use authorization of vaccines as well as therapeutics in regards to COVID. And really, before we dive into the science, I do want to acknowledge a couple of things. So COVID is a rapidly evolving landscape that continues to be true, and in response, guidance and therapeutic recommendations continue to evolve very rapidly as well. What is true today may not be true tomorrow and will most likely not be true 2 or 3 months down the road. We also need to acknowledge that there are many health disparities associated with COVID, especially when we're looking at race, socioeconomic status, and then residing in rural versus urban areas. I think it's also important to know that there are many lenses or perspectives to view the situation from, and those can create conflicting priorities. For myself, am I looking at this situation as a ID or infectious disease purist? Am I looking at it as that and a pediatrician? Because sometimes those can have competing priorities. And then we're now entering year 3 of the pandemic, and this has been an extremely difficult time for so many reasons, but there's been constant uncertainty. We've had to adapt rapidly. We know that there is misinformation and lots of conflict. And I think this is true of educators and healthcare workers right now. We're all just kind of hanging in there by a thread. So now we'll sort of start talking about the science. Not really a surprise. This has been sort of in the news in the last several weeks, but Omicron is the primary variant in Nebraska right now, and really nationwide that's true. This virus, this variant has become more easily transmissible from person to person. And what that means is that we're now seeing record numbers of cases. I think when we started the pandemic way back in 2020, there was sort of this perception that pediatric patients didn't really get sick from this, and maybe didn't even actually catch COVID at all. I think in the pediatric community, especially with our peers on the coast, we knew that kids were getting sick. And very sick in some cases, but at the beginning of the pandemic, pediatric cases were really only 2.6% of all cases. As the pandemic has progressed, especially with the advent of Omicron in the United States, the percentage of pediatric cases has grown significantly, and especially back in the earlier or sort of late 2021, vaccine hadn't been approved for pediatric use yet. Certainly with record number of cases, we are seeing record number of hospitalizations for children and teens throughout the United States. This is certainly true in our region and in our state. As someone that was in the hospital taking care of patients in August, in October, and then in January, we are absolutely following this trend and are working towards these record number of hospitalizations. What does the spectrum of disease look like in pediatrics? Well, it really can vary. So kids can be anywhere from sort of have asymptomatic disease or have, cough, congestion, runny nose, like they might with any other viral upper respiratory infection. Certainly, there are some children that have sort of moderate disease. They may require hospitalization. They may require some respiratory support with some type of oxygen therapy. And then we have all the way to severe infection with associated respiratory distress syndrome, requiring mechanical ventilation and what we call ECMO. So in this picture right here, you can't even really see the patient, but the patient is a baby. They're actually right there surrounded by all of this equipment. Over here on this side, we have tons and tons of medication pumps that are giving medications to our patient. We have chest tubes that are coming out here. We have a breathing tube and a ventilator over here. And because the lungs are actually in such poor shape, even a ventilator isn't enough to actually get the oxygen to the patient. So we have to pump their blood out to a machine, oxygenate that blood, and then send it back to the body. So again, a full spectrum of disease. There are some risk factors that are similar to those in adults that make you more likely to have severe disease. So things like underlying cardiac illnesses, kidney problems, elevated body mass index, although you can still have severe disease even if you don't have any of those underlying risk factors. So again, a spectrum, kids can land anywhere on this. We are now starting to see more kids in sort of this moderate and severe category that are getting admitted to the hospital. If acute COVID wasn't bad enough, infection makes you at risk for something called multisystem inflammatory syndrome in children. So this is a syndrome that occurs several weeks after your acute COVID infection. Anywhere from about 2 to 6 weeks is where we typically see this. And it's a really severe hyperinflammatory syndrome. So the body, the immune system sort of gets revved up and there's tons of inflammation, and this inflammation actually damages many of the organs. So there can be liver damage, kidney damage, cardiac damage, lung damage. And this syndrome can really happen after any type of acute disease. So this can happen to kids that had that asymptomatic infection that we may not even know about, or this can happen to those kids that have had severe disease. The incidence is estimated between 1 in approximately 3,200 infections. This is disproportionately a severe complication. About 60 to 70% of kids with this MIS-C are admitted to intensive care, and there is certainly a risk of death with this. So at Children's Hospital, since the beginning of the pandemic, we've had over 100 cases of MIS-C. And again, many of these children have suffered multi-system organ damage, of which some of the most concerning is cardiac complications. So they have heart damage where their heart isn't pumping very well and working well. They can have dilation of their coronary arteries, which are the blood vessels that feed the heart. And these children, again, many of them require intensive care in the hospital. This is a gentleman that was admitted to our hospital earlier in the pandemic and was in the ICU as well as the regular hospital. And once these patients go home, they're actually not done with healthcare because of the complications of this syndrome, especially the cardiac complications. They require ongoing follow-up and specialty pediatric care. Children are also at risk of other post-COVID conditions. So we've heard about sort of long-haul COVID in adults. Children can also have that, although it appears to be less common than adults. And again, can happen after anywhere on that acute disease spectrum. So symptoms are very similar to adults, including fatigue, headache, insomnia, trouble concentrating, muscle and joint pain, and cough. They may have limitations of their physical activity, certainly mental health, and then decreased school attendance and participation. And this is a big problem. When you think about a child that's so exhausted that they can't physically attend school for a month or more, we know that there are going to be long-term complications from that, and that's going to impact their learning and many other things. So along with the spectrum of illness, we have different therapeutics that we can use at different stages of illness. Certainly treatment in pediatrics, not all medicines are for all ages. We are limited based on age and size of patients with many of these therapeutics. And then with the Omicron being the dominant variant in our area, we lost some of these therapeutics. Because of the change in the virus, these no longer work so that we cannot use them. Ideally, with any illness, the idea is always prevention, right? We want to prevent kids and everyone from getting sick so that we don't have to use these therapeutics and they don't get sick and have to come to the hospital. And the most effective way to do that is through vaccination, which is now available for everyone 5 and older. And we're going to come back to that later in the presentation. I do want to now switch gears a little bit and talk about kids, COVID, and school. So the American Academy of Pediatrics continues to believe in the importance of in-person school with the implementation of strategies to reduce the risk of transmission of COVID. And that's because we know there are so many benefits beyond academic instruction that children receive from attending school. They learn social and emotional skills. For many kids, it's a source of reliable nutrition and physical safety. It may be somewhere where they receive therapy services, mental health services, health and dental services, and provides opportunities for physical activity that they may not otherwise have. And while teachers and educators did a fantastic job pivoting in the pandemic and having remote school, we know that remote learning exacerbated existing education inequalities and inequities and was found to be detrimental to academic performance for many children. And then it greatly exacerbated the mental health crisis among children. So from all pediatricians, a sincere thank you to you all for all you are doing and have done for kids throughout the pandemic. You're doing great things for them. So I'm going to finish by talking about some strategies to reduce COVID-19 transmission. And really, these are endorsed by the American Academy of Pediatrics. We're going to focus on vaccination and know that we're recommending, the AAP recommends that all eligible individuals should be vaccinated for COVID. And vaccination is something that is supported by many infectious disease societies. So the Pediatric Infectious Disease Society, the Infectious Disease Society of America, and on and on. We know that this is an effective tool. And then we also know that masking helps slow the spread of COVID or prevent the spread. And the AAP recommends that all students older than 2 years of age and all school staff should wear face masks regardless of vaccination status. So let's talk about pediatric COVID vaccination. This is something that really sort of came about for the younger age groups in early November of 2021. So somewhat relatively new. At this time, there's only one vaccine that's available for the pediatric age group, and that's the Pfizer-BioNTech vaccine. So we divide this into 2 age groups, the 5 to 11-year-olds, and they get what we're calling a pediatric dose. So it's about 1/3 of the adult dose of the vaccine. The doses are at exactly the same time points as older children and adults. So it's 2 doses spaced 21 days apart. Certainly there are individuals that may qualify for an additional dose if they are immunocompromised and have some sort of immunodeficiency. At this time, no booster is recommended for the 5 to 11-year-old age group, although that may change as these kids get further out from their primary series. 12 to 17-year-old age group, so they actually receive the same dose of the vaccine as adults, and again, the same schedule, that 2 doses, 21 days apart, and then with some individuals qualifying for an additional dose. Everyone 12 and older is recommended to get a booster, and this would be 5 months after completion of your primary series. Do want to say that it's absolutely safe to get this vaccine in conjunction with other vaccines. So it's okay to get your COVID vaccine at the same time as your flu vaccines, or at the same time as kids are receiving other routine immunizations. We will talk about vaccine safety. So to dispel a couple of myths, you cannot get COVID-19 from any COVID vaccine. and there is no evidence that COVID vaccines cause fertility problems. So we anticipate that there will be typical vaccine side effects, things like pain, redness, swelling at the injection site. Certainly with any vaccine, there's the risk of a severe allergic reaction like anaphylaxis, but that's rare. Again, serious health events after COVID-19 vaccination are rare. Know that there is lots of ongoing monitoring. One of the things we do need to talk about in association with the pediatric vaccine is that there have been cases of myocarditis, which is inflammation of the heart muscle, and then pericarditis, which is inflammation of the outer lining of the heart, that have been reported after vaccination of children ages 12 to 17. So these reactions are very, very rare, approximately 54 cases per million doses, administered specifically to males between 12 and 17-year-olds. And the highest incidence is in 16 to 17-year-olds. So this happens almost exclusively in 16 to 17-year-old males. At this time, we don't know exactly why this happens to them. The good news is that their cardiac function returns to normal faster than many other types of myocarditis. So we're at risk of developing myocarditis from a variety of things, other viral infections, parasites, chemicals, things like that. But these kids that get it in response to the vaccine do very, very well. And by 3 months from developing this, most patients are fully recovered and have no long-term effects. Why is vaccination so important? So this is really looking at data in 12 to 17-year-olds and really June through December of 2021. The green line here is the rate of hospitalizations in fully vaccinated adolescents. The blue line is in unvaccinated adolescents. And you can see that there's a large divide there, where vaccinated individuals really are not getting hospitalized very often, but those that are unvaccinated are getting hospitalized and are often having severe disease when they're admitted in the hospital. So this data was actually pre-Omicron, but we want our teens and young children to get vaccinated. We know that vaccination plays a significant role in reducing hospitalizations and as well as decreasing the severity of disease. Well, what about vaccination for children under 5? So the Pfizer trial for 6 months to 5-year-olds is ongoing right now. So initially the trial was designed to receive 2 doses 3 weeks apart, again, the same schedule that the rest of us are on. So after the second dose, the 6-month to 2-year-old age group met target immunity. The 2 to 5-year-olds did not. What is very reassuring to take away from this study is that there were no safety concerns identified in either age group. What they did then was revise the trial and added a 3rd dose at 2 months after the 2nd dose. So for this age group, it will likely be a 3-dose primary series. We're all very anxiously awaiting this data, and we're hoping to have results and hopefully have vaccine available in this age group under an emergency use authorization in the first half of 2022. Well, why did we add a 3rd dose instead of looking at a higher dose? One, we didn't need to restart the trial and restart data acquisition, but we also have data showing that with these newer variants that you receive better protection when you have 3 doses of vaccine. So how are we doing in Nebraska with vaccination rates? I have to say, not great. So if you are in a grade school or early middle school classroom, about 1 in 5 of your students is vaccinated. If you are in maybe 7th grade and up, maybe a half of your students are vaccinated. And you're probably saying, well, Dr. Skar, that's because they haven't been eligible for the vaccine for very long. Well, these numbers really haven't shown much growth over the last several weeks. So in the beginning, when vaccine became available is when we had a big rush of people to get vaccinated. And since then, we really haven't seen the percentage of fully vaccinated children and teens grow very much. We also know that in our state, there's a gap between urban and rural vaccination. This was from the World Herald over the summer. When I looked at the data from DHHS earlier this past week, again, you can see that we have higher vaccination rates in some counties compared to others. So we need to do better here in Nebraska. And what we're doing as a medical community is an initiative called Max the Vax. So this is a joint effort between the Nebraska Department of Education and Children's Hospital. Max the Vax is a program or an initiative that encourages parents to act now and get their kids vaccinated against COVID-19. So this provides family with vaccination resources and information from Nebraska physicians and healthcare providers. It's a reliable source of information, and it really helps parents and guardians get answers and stay informed. There are many downloadable materials for families as well as medical providers with FAQ sheets, posters, parent handouts. And this resource is actually multilingual, so comes in many different languages, English, Spanish. Handouts come in Kirin, they come in Arabic, and many different things. So this website is available for the public. The website is www.maxthevaxne.org. And it's something that we encourage providers to look at as well as family members. I love that we have this many kids vaccinated. That is something to cheer about. But again, we have a lot of work to do. So this initiative is supported by over 200 providers throughout the states. 11 different communities are represented. We're really working to get the message out about vaccination because we know that it's so important for kids. I'm going to end by touching on masks. We know that masks help stop the spread of COVID in schools. There were some studies out of Georgia where it was demonstrated that schools without mask requirements were 3.5 times more likely to have COVID outbreaks compared to schools that started the year with mask requirements. So really it's wear a mask with the best fit, protection, and comfort for you. If you look at these, it's kind of, I'll say, okay, good, better, best protection. Although from personal experience, wearing an N95 for hours on end is not particularly comfortable. But as pediatricians, we think it's so important for children to be vaccinated and then to be masking as well. And at this point, I will turn it over to Dr. Lawler, and he can continue on with our other topics.
Thank you very much. That was really informative. As a grandma of 10 kids, it is very important for me to know all of these. And as an educator, it's really important for us to share the Max the Vax and get the proper information out. So I'm sure we'll have some questions for you, Dr. Skar. Thank you very much. And with that, we will turn it over to Dr. Lawler. The floor is yours. Thank you.
Thank you, Jenny. Hi, everyone. Thanks for having me talk to you. This is it's really a privilege to be able to spend a little bit of time. Hopefully, folks can see my screen now. I'll take that as a yes.
Yes, we can.
Okay. So I think it was really important what Dr. Skar talked about in terms of the number of children we're seeing with COVID-19 now, and the number of hospitalizations that we're seeing, which is really a better indicator of the number of true community infections, and also the fact that our vaccination rates, as Dr. Skar also pointed out, among kids are so much lower than they are among adults. And I think this hopefully begins to erode away at this myth that has unfortunately been very popular, not only in the lay press, but even among medical professionals who probably should know better looking at the data. And that myth is that there have not been a large number of COVID infections in children, and also that COVID infections are not occurring in schools and that we're not seeing higher rates of COVID in schools. And so I would argue that perhaps it's true that we're not seeing a higher rate of COVID infections in school, but that's only because we're not looking. And I'll point you to these data here that are from, sorry, I'll go backwards here. This is the CDC's nationwide antibody surveillance study that looks at blood that's at commercial labs. So tested for other reasons and getting blood chemistry and blood count from commercial laboratories. And they take that serum from the blood and they do antibody studies on it. And so they can actually specifically look for antibodies that are directed against a virus protein that's not, it's not in the vaccine, which is targeted at the spike protein, which you may know the mRNA vaccines and the Johnson & Johnson vaccine encode for spike protein. So those are the antibodies that you generate when you get vaccinated. But when you're infected, you also develop antibodies against other proteins in the virus. And one of those proteins is the N protein. It's actually the antigen that's detected by many of the rapid antigen tests that we use. But the N protein, you can only get antibodies against this protein if you've been infected with the virus. And what we can see here is this goes all the way back, rolling the clock back to August 20th. So we had already had a couple of large waves of COVID-19 at that point, but you can see that everybody across the different age groups is relatively similar in terms of who has antibodies and who doesn't. You can see even at that point, kids were already starting to edge ahead, but roughly equivalent with everybody else in early August of 2020. Now, when you fast forward to the latest data we have, which is from November of 2021, with a full school year and a little bit of another semester under their belt, you can see that children up to the age of 17 had dramatically higher rates of antibodies against the N protein than any other age group. And the only explanation for this is that children ages 0 to 17 are getting infected at a higher rate than anyone else. Now, if you look at the laboratory confirmed data for COVID cases over that period of time, most of our diagnosed COVID cases occur in middle-aged adults and not kids. And so what it shows is that while we test much more frequently and detect cases of COVID much more frequently in older middle-aged adults and seniors, because they're more symptomatic, because they get presented for testing more commonly, the bulk of cases actually occurs in children 0 to 17. And when you break that data down a little more, it's in kids between 5 and 17. So it's school-age children. Now, if you look at data from the UK recently, their data supports this as well. So the UK, while they've essentially rolled back almost all of their non-pharmaceutical interventions and have essentially let the Omicron wave just kind of ride on its own, they still actually have relatively aggressive testing protocols among children in schools. So their schools have been testing regularly, often once a week for kids throughout this year. And so what you see is that once school went back in after holiday break, everybody else, all other age groups, went down in their incidence, and that tracked with the overall decrease in Omicron cases that we saw in the UK. But you see that school-age children there actually started to go back up once they got back into school. And we've seen this over and over again in places that actually do aggressive surveillance of school-age children. You see higher rates in those school-age children than you do in the rest of the community. So when you look, you actually find these cases in kids. The reality is we just don't look in the US. We test kids at a much lower rate than we test any other age group. Now, why are schools such an important place for transmission of COVID-19, it's because they're an important place for transmission of all respiratory viruses. We've known this for a long time. In fact, studies of influenza have demonstrated pretty clearly that schools are the initiator and so to speak, the kindling for outbreaks in the community. It's generally the schools that really start the outbreaks going, and then that moves through older populations in the community. And it's because viruses that are transmitted by respiratory secretions, particularly those that can be transmitted by small droplets that travel through the air, are most readily transmitted in high density settings indoors, where there's poor air exchange. And that pretty much describes most school buildings. They are packed full of children. In fact, of any building in our community, schools have the highest per square foot population density of any other location in our communities. And then think about school buses as well, where kids are riding back and forth from school every day on school buses. And more kids actually take school buses every day during normal times than all adults who take public transportation in the US. So schools are a high-risk environment. And for COVID-19, particularly so, because we know that the SARS-CoV-2 virus, the virus that causes COVID-19, is transmitted primarily by airborne droplets. They are small respiratory droplets that contain virus particles that you exhale from your mucous membranes. These droplets get brought into the airstream that you exhale, and then you breathe them out. And those droplets are small enough, and when they reach the outside air, especially when it's dry, as it is in the winter, they shrink and dehydrate to the point where they become particles in the micron and submicron range that allows them to behave like a gas. And they disseminate through whatever indoor airspace and concentrate, if there's poor ventilation, in that indoor airspace and create the hazard. So remember, you don't get infected by one single virus particle. You have to get a sufficient dose to overcome all of the innate immunity that you have. And so it probably takes thousands of virus particles to actually infect you. And so your exposure is related to how much virus is floating around in the air and how long you're exposed to it. And people exhale virus particles in these small particle aerosols when they are infected. And often these people are asymptomatic, so they don't even know that they're shedding virus, or they have mild symptoms. And especially in kids, we know that they more commonly have very mild symptoms or even no symptoms when they're infected with the SARS-CoV-2 virus. Now, this graphic is it was a really good review of airborne transmission and mitigation and risk in indoor environments. And it shows a person breathing, and this is a special type of camera that allows you to see these small particle aerosol droplets above in this person who's not wearing a mask, and below when this person is wearing a mask. And you can see that in columns A and D, this person is breathing normally. And you see that there's a plume of airborne droplets that is in front of the person's face as they are exhaling. And those get swept up into the air currents in the room and moved around. And you can see that in the above picture in picture frame A, the plume is much larger and it's much more concentrated because in D, the mask captures a significant number of these particles. In B, now this person is talking in a conversational voice, and you can see that now they project this plume even further forward. There's more aerosol particles that they generate, and they project it forward, putting people in front of them at higher risk. You can see the person in the bottom wearing the mask when they're talking. That plume is filtered significantly, and there's much lower amounts of virus. In the last picture frame, C and F, this is when the person is laughing. And we know when somebody forcefully expires air, either from laughing, talking loudly, or singing, you dramatically increase the amount of aerosol particles with virus that you secrete. And so you can see when this person is laughing, he is shooting a giant plume of airborne particles. And again, if you were infected, these would have virus in them, a long distance and a much larger number of particles than when he is breathing normally or even just talking. And again, you can see with the mask, there's more than there was with talking or just breathing, but again, much less because many of these particles are getting filtered by the mask and those that aren't are getting directed upwards and downwards. So they are not at least creating this giant jet of virus that's projecting out in front. And so this is why masks are so important in indoor environments, because it's not necessarily the mask on the person exposed that's important, although that does have filtering capability and does provide protection for the wearer. The real protection is in preventing this shedding. So people who are shedding virus, especially those who are shedding it asymptomatically, if you have masks on them, you dramatically reduce the amount of virus that they're putting into the air. And this reduces the exposure to everyone around them. So how much are we exposed? It really depends, again, on the indoor environment, how long we're in there, and how good the ventilation is. This is a graphic in the same article that's from an office building, and it shows the concentration of carbon dioxide in the air. Now, carbon dioxide in an office indoor environment really only comes from one place, and that's from the breath of people who are in there. And you can see this graph really shows that. When nobody is in the office building, is at these troughs here. And this is again over the course of a week. So you can see very low troughs of carbon dioxide concentration. And that's when nobody's in the building. It's in the middle of the night. And then when everybody comes in the morning, you can see that jumps up significantly and spikes throughout the day and then goes back down. And so these concentrations can reach relatively high levels. It is recommended that, for instance, the Japanese public health authorities actually monitor carbon dioxide concentrations inside rooms to gauge risk for COVID-19. And when concentration of carbon dioxide gets over 700 parts per million, and certainly over 1,000 parts per million, they think that is significantly high risk for transmission. And you can see that every day in this office environment, the concentration goes well over that, usually twice what is the recommended concentration of carbon dioxide, which again is a good proxy for how much virus would be in this room if there were infected people present. And you can see that that virus also, the amount of carbon dioxide goes up depending on the height in the room. And this has to do with how most ventilation systems work in rooms and where people are breathing. So you can see that right around 1.5 meters to 2 meters. So again, that's around 4.5 feet to 6 feet is where the most virus is. And that's where most people's heads are. Maybe the really little kids are a little below that. But in that environment, essentially, you can see that your exposure to virus in an indoor environment is going to be quite significant unless you improve the ventilation system inside your office building or inside your school. Now, again, offices have much lower population density than do schools. And so in many schools, you can achieve CO2 concentrations much higher than this, which again means you have much more exhaled breath floating around in that room than is safe when you have a high likelihood that somebody is exhaling virus. Now, how do you mitigate the risk of COVID-19 transmission in schools? It's been shown in multiple studies that if you layer a series of interventions together, you can dramatically reduce the risk of transmission. This has been shown very well, especially in colleges, because a lot of colleges have implemented these aggressive procedures and then actually measured them. Whereas it's been very difficult to get these types of data in public schools. One very good study that came out not too long ago was actually out of Delaware State University, which is a historically Black college and university, obviously in Delaware. And they reviewed the protocols that they had taken during the last school year, 2020 and 2021, and the impact on transmission on campus. And you can see that their safety protocols were integrated and multi-layered. They wore face masks at all times on campus, indoors, and even outdoors, and only in residence rooms were masks not allowed. They de-densified their dorm rooms so that they tried to have not triples of 3 in a dorm room. They reduced to 75% their overall on-campus residency. They also had a mix of in-person and virtual classes, so they de-densified some of the classrooms. They did social distancing measures on campus. They did not have large events. Dining was primarily grab and go. So they did not have large numbers of people sitting together unmasked in dining rooms. And then they had this twice weekly PCR testing surveillance system for all students on campus and all staff as well, which is, again, something that many of the successful schools have done. Now, they had about 51 or 52% adherence to this. So it probably turned out more likely that it was about once a week testing, or, lots of students got tested twice a week. Some didn't get tested. Nevertheless, they had a pretty aggressive testing campaign where most students are getting tested at least once a week. And then those students that they detected who were shedding virus were isolated in special rooms, and then close contacts or high risk folks were also quarantined. And what they found, I thought I had the graphic in there. Well, what they found is a dramatically lower rate of positivity among their students compared to the general population of Delaware across the epidemic wave in the fall of 2020 and in the spring of 2021. They had several fold reduced percentage of positive cases. And they didn't have to interrupt learning. They were able to continue in the spring, in the fall, in the spring, and then again this fall with their on-campus learning with this layered approach. And so this, I think, again, echoes what we've seen in other successful school strategies where this combined layered approach works. And that layered approach should consist of up-to-date vaccines for staff and students. And that means for many kids, certainly those 12 and older, should have a booster, because many of them will have had their series completed 5 months prior. And certainly for staff, that should mean having a booster. It means wearing face masks all the time, indoors when together. It means dedensifying classrooms and other rooms when that's feasible. I'm sorry for the spelling error there. And it means increasing ventilation of rooms. So again, you reduce the exhaled breath that is present at any given time in that room that's containing virus particles. That can be done by opening windows when you have moderate weather outside, or by increasing the air exchange rate in your HVAC system, which could also incorporate high efficiency filters if your HVAC system can manage that. Mitigation also should include limiting unmasked contact. Some of the higher risk times are at lunch or right before or right after school, where kids may be congregating together before classes and not wearing masks, at extracurricular activities, where kids are potentially gathering as well without masks, taking special mitigation protocols for sports and music related events. So as you can imagine, if you increase virus, the amount of virus you expel when you're laughing or singing, music events can be the highest risk events we've seen. And that has been demonstrated in multiple large outbreaks associated with concerts and singing events. And it's also true that wind instruments produce large plumes of virus as well. Not surprisingly, when our team did surveillance of environment and air sampling in classrooms in OPS, we found that the choir rooms had the highest rates of detection of virus. And then other high risk situations like sporting events and other extracurricular activities. Another part of this layered approach, which I think is critically important, is this idea of school-wide testing. So testing should be broad and in a surveillance system that just does not look for symptomatic kids. It should try to do as many asymptomatic kids as possible in a regular fashion, so you detect these potential transmission risks early. It is probably true that the most number of transmissions occur from people who have no symptoms or very mild symptoms. And that's been demonstrated in a number of different studies, because these people don't realize that they're potentially sick. They go about their normal activities. People come in contact with them more commonly. And that's how large clusters generate. And then finally, a critical component is anybody who's feeling ill should stay home, and that any high-risk contacts of those ill persons should be quarantined. So that's all I have in terms of mitigation strategies. Finally, I was asked just to provide a couple of comments on what the future will hold for the pandemic. I think it's been dangerous to predict too far into the future what will happen. I think a number of people I've heard and a number of the prominent voices who are deemed experts on Twitter and other places have seemed to indicate that Omicron is the end of the pandemic, and that after we're through with this wave, everything will be kind of at an endemic phase and we'll go back to normal. Unfortunately, I'm not sure that that's the case. There's nothing really to indicate that the virus has exhausted all of its opportunities to create new variants. In fact, we know that as we give the virus more opportunities to mutate through large outbreaks in communities anywhere in the world, and we have partial immunity in those communities with populations that are not well vaccinated, we create the chance for the virus to mutate into a new variant that could potentially be more transmissible. We're still watching this new sublineage of Omicron called BA2 that's been causing a huge acceleration of infections in Denmark, who even after they had their large initial Omicron wave, now they seem to have taken off with kind of this second rocket trajectory with BA2. It's unclear whether that is going to be the next concerning variant coming down the line, but I think it's probably a safer bet than not that we will see additional variants come. And until we get a larger proportion of the population that is up to date on vaccines and looking at the transmissibility of these variants, it means that we probably have to get well over 80% of the population up to date. That means actually boosted or at least vaccinated within a few months to get strong community protection and to reduce transmission rates below where we can essentially return to normal without having large outbreaks. Eventually, I think if we continue to have epidemic waves of new variants, enough people will be infected. And certainly by the end of the Omicron wave, it's estimated that well over 50% of Americans will have been infected by COVID at one point or another. It's probably going to be closer to 75%. And it's true that if we get enough infections multiple times, and we have good vaccine coverage, we're decent now, that eventually we'll get enough immunity across the population that will start to suppress things to turn COVID into something more like flu, where we see these large epidemic waves, but they're not huge. They don't cause the health system to be overwhelmed. And it's something that we potentially live with, although living with COVID so far has resulted in almost 900,000 dead Americans. So that's not necessarily an ideal situation. And we don't really know how long it will take to get to that level of immunity. Certainly one infection does not seem to give great long-lasting protection against future variants. And it may be true that even after multiple infections, you still don't have great long-lasting immunity. We'll just have to get more data to see. So it's quite possible that we could see another year or even two of what we've experienced now, unless we can get much higher rates of compliance with vaccines. And that may mean multiple boosters as we continue to go forward. Hopefully we'll improve vaccines and be able to generate more universal vaccines that have longer lasting immunity. But at the current time, those are still under development. So that's what the future potentially holds as far as I can tell. And I'll wrap it up, and I think we're happy to answer any questions.
All right, thank you so much. Good information. Like I said, I really am learning a lot on the Tuesday, Friday calls that I listen to, and I'm pleased that we have a good portion of folks out and we've recorded this information. Dr. Blomstedt, do you want to join us again? I know we have a couple questions in the chat, and they have to do with schools, and some of them may be Matt's answers, or you may want to jump in as well. I know that we have been talking about dedensifying, which was huge at the beginning. We had lots of Facebook lives with folks that have come on and talked about different things. Um, and it's a very good question. You know, right now we are in a teacher shortage, just like you are in a healthcare worker shortage. And so de-densifying classrooms is very difficult when we're short on staff. Matt, did you want to take a shot at that, or doctors, if you have anything that could help with that as well? So, Matt.
Yeah, and certainly, obviously, we've gone through a lot of different strategies, and schools have gone through a lot of different strategies. Dr. Lawler did a good job of describing the importance of masking and how that works, different settings, different kind of protocols that might be in place. But de-densifying, keeping a distance, I guess, is the way that we really looked at that. Ensuring, I guess, other strategies like ensuring ventilation's in place. It is a lot tougher in the wintertime than it is maybe in other times of year, especially depending on the type of air handling systems that schools have. And so, what I think I've witnessed anyway is as schools are facing out any type of outbreak and they're realizing those cases are hitting. I think, again, Dr. Lawler hit on a few of those points where they might build asymptomatically, and then you start to see that spread and really see that impact in schools. I know it's really I guess hopeful anyway, as folks are seeing that they go back to some of those protocols. If they weren't using those protocols, pretty much those protocols that we laid out over the last 2 years are known to work, and so gives us a good chance to be able to do that. So it's a great question, and I know maybe part of the nuance of the question is also with the staff shortage. We know we've had to consolidate settings, so I would just encourage folks to use the largest settings as possible for that as well.
And I know that we have some legislation right now working on those staff shortage issues that we have across the state, as we've said, in the medical field as well. One of the other questions in the chat was about testing in schools. And Dr. Lawler, you talked a little bit about how that is very prevalent in other places. I know that we have worked with HHS. They are providing some testing. I don't know if those are being done in schools. Is there any way we can get more tests to schools in order to get some valid data as well? Anybody want to answer that one?
Well, there have been resources made available from the federal government to support school testing. To be honest, not many public school systems across the country have taken them up on that offer. In part, it's been difficult, I think, for them to come up with a strategy and find folks, but there are testing resources that are available. And certainly a number of private schools have done that. But obviously they have resources, and you're generally talking about one school, right? So it's not an entire system. And certainly colleges, a number of colleges have developed their own testing systems, including UNL is doing saliva-based testing, as are schools, other schools in the Big Ten, I think Michigan, Purdue, Indiana, and then a lot of the schools on the East Coast. So those schools that are doing those routine student testing programs have shown dramatic success in keeping campus levels of transmission and overall case burden low. But it requires, it's certainly not a small feat to do that type of saliva-based testing, and there's ways to do pooling and other things to get the cost down considerably, but I don't think it's necessarily funding that is the limiting step here. It's kind of in the logistics and coordination, but certainly there are folks who can do that. Dr. Broadhurst in our emerging pathogens lab has a saliva-based PCR testing that she used in her OPS pilot, and that we're actually using at UNMC. So any UNMC staff or student can go get their saliva collected in a building on campus. I'm trying to go twice a week. I'm usually going at least once a week, but usually hitting twice a week. And I usually go by noon and I get my answer back by 3:30 or 4.
Excellent. I know that you said that OPS did do a pilot program, and that was last year during the school year. And I know that maybe some folks are looking at that again as an option to figure out, you know, looking at the testing to help us with that mitigation as well, because there are so many asymptomatic folks. My granddaughter being one of them. She you know, it was like surprise, you know, she had no symptoms whatsoever, but she had been exposed at preschool and she was positive. Um, so we, you know, I mean, we have that experience on our own homes as well. So I do not see any more chat questions in the chat. Attendees, if you have another question, please put it in the chat now. Otherwise, you know, I'm going to wrap it up. We said it would be about an hour, and it has been. And I really genuinely appreciate the information. We have that information now, and we'll be able to share that with folks as well. I think that, you know, the group that we have on, we're also very interested in learning about this and sharing it. You know, part of what we need to do is to get the communication out to as many people. And I know that I read things on social media about vaccines and about boosting and how many boosts do we need, and, you know, just really negative things. But I do, and I have said from the very beginning of this pandemic, is that we like people to look at us as educators and to say we know what's good for kids, we know what's good in our professionalism, and we genuinely appreciate the experts in your field, Dr. Lawler and Dr. Skar and Dr. Blomstedt, for continuing to work with our education system across the state. And we will continue to work together to help make sure that our students are learning and that we are keeping them as safe as we can, and our staff as well. So thank you for joining us tonight. I don't see any other questions, and we will see you soon. Thank you.
Thank you.
Good night, everybody.
Thank you.